My name is Merryn Simpson and I'm Chief Executive of the organisation that is hosting today's webinar, the Health Creation Alliance. There has been a lot of interest in this topic on measuring health and wellbeing outcomes in communities. And we've been both surprised and delighted by the numbers that have signed up for this webinar today. I think the level of interest says a lot about the shifts that are taking place, expressed in the 10-year health plan, the shift to prevention, to community and neighbourhood health. It also says something about the climate for public sector finances and for community sector finances as well. But I think it also says something about the desire to do things differently, and that is now broadly accepted among many people now across public services, that we need to look at health differently, not just about treating illness or even preventing ill health, but actually how we create health in communities. So community organisations are the backbone of local life, and building connection, responding to needs and ambitions, and strengthening the social fabric that underpins health and wellbeing. And at our recent Partnership Summit in October, we explored why it is that health must be seen as an investment in people and communities to do this work, and not a cost to the public purse. And that's a message to Treasury, but to all of us as well. It needs to be seen as an investment. So the key question today is, how might this research help to bring clarity around how best to invest in community health and wellbeing? I'm just going to tell you a little bit about the Health Creation Alliance and about our collaboration with Glasgow Caledonian University on this research. So the Health Creation Alliance, we're the leaders in health creation to address health inequity. Health creation is happening all around us in many places, in pockets, but our ambition is for it to be happening everywhere as a matter of course, business as usual, so that people from communities that have the worst health outcomes really feel the difference. We define health creation as the process through which individuals and communities gain a sense of purpose, hope, mastery, and control over their lives and their health and their environments. Because when they gain that purpose, hope, mastery, and control, their health and well-being are enhanced. So the Health Creation Alliance, we're a community interest company and we're a member movement, so anyone can join. Any professional from any sector or community setting, or if you have lived experience of poverty, trauma and discrimination, then you're all very welcome to join this energetic and impactful movement, making health creation a reality. We provide vision, narratives and expertise to enable a shift to a health creating approach. We support and design delivery of national programmes, for example, Core 20 Plus Connector programme, and we support system change on the ground. So we bring our deep expertise to the task of developing out health creating neighbourhood health, for example. And we host events and influence policies and provide communications to support change. So these are just a few of the things we do. And what makes us different is that we look with communities through the community lens principally. The service lens is very much secondary. So looking through that community lens helps us to see what communities see and experience. And it gives us a different perspective that has enabled us to develop what's turned out to be highly effective hyperlocal approaches to trust building, working with communities and system transformation. So if you want to find out more about the Alliance, do have a look at our short annual report that's being put in the chat, and also the outputs from our recent summit. You might be interested in those. So when it comes to our collaboration with Glasgow Caledonian University and this webinar today, we're delighted to be working with Professor Rachel Baker and Sarkis Manoukian from the Yunus Centre for Social Business and Health at Glasgow Caledonian University. This collaboration started around 6 years ago, and it takes that long to get a study as complex and as sophisticated as this conceived of, funded, off the ground and completed. And we're one of many partners, and we did of course have COVID to contend with in the early stages of this project. But But Health Creation Alliance wanted to be involved because we've been asked many times to substantiate our claims about the causes of health, meaning providing evidence that gives highly trained professionals confidence to take action. That is a tall order, not least because, like there's an inverse care law, there's also an inverse evidence law. And I know Rachel's going to say more about this in what she says, but for me, that means that until very recently, very little money has been made available to research well-being and the causes of health, or to research what the solutions might be, particularly for communities with the poorest health outcomes, or to involve people with lived experience in that research, participating in it. Far more has tended to be invested in research and analytics that's focused on telling us what's wrong in communities that have the worst health outcomes, or on clinical solutions to the illness that results in. So while there's some excellent work going on, including by many of you who are attending this webinar today, I think it's fair to say that until recently it's been largely happening under the radar. So being involved in this research, we are hoping that we can uncover in a much more sophisticated way what it is about being community-led and what community-led organisations do that actually creates health. Health Creation Alliance has not been doing the research. What we've been doing is leveraging our connections. We've been convening experts from across many communities and sectors. We've been helping with sense making. So we held 2 roundtables about a year ago to help with the support sense making for the findings that were coming out of the research. And we are doing some communications to support action that will create change. So the research itself is pretty unique because of its size and scale, because of the range of organisations and the activities that are embraced in it, and the range of methods that it draws on. It's a realist evaluation, and Rachel will say more about that, but essentially it enables multiple methods to be brought together across multiple sites. It helps be able to navigate patterns of data and analyse them, and you can see nuances in that data that are brought to the fore. So it's quite a special method in that respect. And today we're going to focus on the quantitative findings because we know that there's already a good body of qualitative evidence in the form of stories and case studies in this area. Of course, a word of caution about the limitations of any research. It's important we don't imagine that this research has the whole story or the last word, but actually that it leads to both action and to new questions, because we know that all good research leads to new questions. So this webinar today, the plan is to have Rachel and Sarkis presenting for the next half an hour or so, perhaps a bit more. Then I'll invite our panel members to introduce themselves, to provide some reflections on what they've heard. Then we'll be having a conversation and we'll bring in some questions from the chat. So please make use of the chat. Please put your questions in there. Steph and Steve will be monitoring that, and we'll be able to funnel those questions through to the panel. Do also introduce yourself and your role and your organisation in the chat so we can get an idea of the reach of this webinar. And Rachel will also be adding her details to the chat. So if you want to get in touch directly, that's fine. And we'll be delighted to sign you as a member of the Health Creation Alliance. And someone will be in touch about that following this webinar. So finally, the webinar is being recorded and it will be made available in the new year on our website and through channels like LinkedIn. So with that introduction done, that's it from me. It gives me great pleasure to introduce Professor Rachel Baker, Chair of the UNAS Centre for Social Business and Health at Glasgow Caledonian University. Rachel.
Thanks again.
Thanks very much, Merrin. I'll go ahead and share some slides. And someone please just let me know that you can see those before I charge ahead.
Yeah, we can see them perfectly.
Perfect. Thank you. Thank you so much, Merrin, for that introduction. I'm really pleased to be here today to talk about the Common Health Assets project. I'm joined by my colleague, Dr. Sarkis Manoukian, who is part of the Unicentre as well, and our Senior Research Fellow in Health Economics. I too am delighted with the level of interest in this webinar, grateful for the Health Creation Alliance's reach in this sense, and excited to get some of our findings out and discussed by an impressive panel of people. Welcome everyone. I hope this will lead to some new connections and some new conversations. Common Health Assets is a multi-site, multi-method research project that was funded by the National Institute for Health and Care Research through their Public Health Research Committee. And we set out to investigate how community-led organisations, or CLOs, impact on health and wellbeing in disadvantaged or underserved areas of the UK. It was designed and conducted in partnership between academic and community sectors in Scotland, England, and Northern Ireland. There's a great deal of richness and detail in the Common Health Assets project, and we won't attempt to cover everything. At the same time, we want to give you a good flavour of the findings and also point you to resources that we have on our website and invite you to follow up with us if you're interested in delving more deeply. Now, some of our work is already published and available as journal articles, open access, and some of it's still under review. So you're seeing emerging findings in this presentation too, and I would encourage you to keep an eye on things that are coming out in the next few months. It was a huge privilege to lead the Common Health Assets project, really rewarding, a fantastic team of people. We had experts in public health, in community development, in economics, mental health, social policy, social innovation, across universities, community-led organisations and community network organisations. And I just don't have time to mention them all by name, even though they are all fantastic. All of those people are on our website with contact details. But even though I can't mention them all by name, it is important before we start to note that the work that Sarkis and I are presenting to you today comes out of that combined collaborative effort across a fantastic team. If at the end of this you do want to ask further questions, even if I can't answer them, one of the team will be able to, and I can point you in their direction. A really crucial part of our research and running throughout the Common Health Assets project was a lived experience panel led by colleagues at Glasgow Centre for Population Health. And this was a group of about 12 people who were engaged with and part of and volunteering in community organisations in our sites, who met at regular intervals during the project and advised us on everything from the design, the methods, the application and conduct of the research, and then later in making sense of our findings and interpretations. They helped to make the research relevant and feasible, but also how to read the findings coming out. And there's a paper published already led by Mahassin Ahmed and Jen McLean, for those of you that are interested in reading more about that particular aspect of the work. So to the research, I'm just going to say a little bit by way of background, first of all. What do we mean by community-led organisations? There's lots of terms used for community-led organisations. And for the purposes of the Common Health Assets project, we were interested in place-based organisations in areas that score badly in terms of indices of multiple deprivation or health inequalities. And these would be likely a community hub, a space, a gathering place. And we use that CLO term to gather together non-profit organisations in the voluntary community and social enterprise sector that are place-based and are community-owned and run. And over 3 years, we worked with 14 organisations. You can see their logos here in Scotland, England and Northern Ireland. And through them, gathered data and insights from more than 400 people. Now, because community organisations are responsive to their communities and to the places they're in, they do different things. But importantly, they have fundamental principles in common about doing with rather than doing to. And I think we might gather that together underneath the sort of banner or label of an assets-based approach to community development, where we are building on strengths, relationships, skills and knowledge and capabilities in communities. So within our community-led organisations, there'll be lots and lots of things going on, from outdoor activities through to creative activities. Lots of them have cafes or soup kitchens, or even one a radio. Community transport, but also services, including advice services on things like finances, health and wellbeing, healthy living, family and children activities. So there's lots of different things going on. These are complex organisations in complex systems. And we needed a study design that could cope with that complexity. So I'm just going to say a few words about the design of the Common Health Assets project. As Maren mentioned, we took a realist approach to the evaluation, and we combined that with an economic appraisal. Realist evaluation goes beyond asking, does it work, at what cost, into a more nuanced examination of what works for whom, in what contexts, and how. So realist evaluation is about also opening that black box and saying what's going on inside. In realist evaluations, we are centrally concerned with programme theories. That sounds like a technical term, but it's really just an expression about how things work. And it's usually articulated in terms of context, mechanism, and outcome. So if we observe a change, through what mechanism did it happen? How did it happen? How did impacts arise? And in what context, recognising that it might not be the same for everybody in every place. Realist evaluation isn't new. There's lots of texts on realist evaluation. Bringing it together with economic evaluation is rather more recent, and there's NIHR funded methodological work that we're involved in going on right now. This is a picture of the whole project, and there's lots on this slide. At the top, you can see our overarching objective or question about how do community-led organisations impact on health and wellbeing. And every circle on this slide is a different, smaller component of work with its own methods and a sub-team around it. I'm not going to go through every single one of those circles, but as you'll see, we're going to focus in on a couple of those in a moment. What I do want to just draw your attention to is that midline on the diagram here. Phase 1 and Phase 2. The study was broken into these two phases and designed so that in Phase 1, we were developing programme theories. We were developing our ideas about how community-led organisations work to produce health and wellbeing. And we did that not from a blank page, but drawing on the expertise that we have in the community and drawing on the existing literature and policy documents. And at the end of Phase 1, we had a number of theories about how organisations work, which we set out to test and refine and revise in Phase 2. And in Phase 2, we were generating new data, testing out the theories on those new data and revising them accordingly. So these are the two areas that we're going to now zoom in on from that big complex diagram: the questionnaire study and the economic evaluation. And as Maren mentioned, we thought that we would focus in on this in part because in the literature in this field, this is possibly an area that's more sparse. So in a moment, I'll hand over to my colleague Sarkis to talk about the findings from the survey and from the economics. And then I will bring us back together and go zoom back out or pan back out, bringing in the broader findings to highlight some key messages that might be of interest to different constituencies or audiences here today. So over to you, Sarkis.
Yep. Thanks, Rachel. So let me just say that it's been a real pleasure working on this project with you and the rest of the team. It has proved to be a very successful project in the end. I would do it again, and that says a lot. I'm very excited to present these results today. Obviously, when you're conducting data collection, particularly in this population that can be difficult to reach, there are always risks, but I'm pleased to report that we did very well. Of course, there were bumps along the way, but everyone in the project pulled together and we delivered a high quality data set, which is a rare thing to have in this field. So we recruited 350 participants across the 14 CLOs and followed them over 12 months, collecting data at 4 time points. We achieved a very high retention rate, 86%. This is excellent for this type of longitudinal study. We measured 4 validated well-being outcomes: capability well-being using the ICE-CAP-A, mental well-being using the short version of WEMWEBs, health-related quality of life using the EQ5D5L, and social connectedness using the revised social connectedness scale. You can think of these as well-being dimensions as well. So what we did, we tracked participants' engagement patterns in the CLOs, looking their total involvement across the activities that they did, the specific types of activities, how frequently they participated, and how these patterns changed over the year. For the analysis, we used a technique called multi-level modeling. So this is a statistical approach that accounts for the nested structure of the data, observations over time, also known as repeated measures, nested within the individuals, nested within the organizations. So this allowed us to control for the demographics, socioeconomic status, organizational factors, but also the fact that these are repeated measures of the same individuals and that they were members of particular organizations. So the approach takes that into account. So the method we've used is robust. The bar for statistical significance was set high. And what I'm presenting today are only the statistically significant results. But I'm not going to focus today on coefficients or p-values, but I will explain everything in narrative terms. If you're interested in the numbers, be on the lookout for the publication, which is under peer review and should be out in the new year. Fingers crossed. Next slide. So the key findings. There were many findings from this study, but today I'll present the most interesting ones. Reality is complex, but we can see clear patterns emerging in the data and the analysis and the results. So the main result was clear. Overall engagement of participants with their CLOs is associated with better capability well-being measured by the ICE-CAP and better mental well-being measured by the short WEMWEBs. This is any type of engagement, any type of activity. So with every session, we can see benefits. We also found that benefits emerge at different speeds. So we can see evidence that social connectedness improves quickly within the first month of participation. But on the contrary, improvements in other well-being dimensions may take longer to emerge. And the socially prescribed and new participants had worse well-being at baseline, but they catch up over the year to other participants. So this is an indication that CLOs are valuable for supporting vulnerable people to improve their well-being. Next slide. And so we now going into activities. So different activities improve different dimensions of well-being. You can see that on this table. So some activities influence all outcomes, while others affected specific outcomes or dimensions of well-being. So looking at the table, psychological support, child and family activities, outdoor activities, they showed benefits across all 4 well-being dimensions. Volunteering, it showed benefits specifically for capability well-being and social connectedness. Physical activities improved capability well-being, whilst arts and crafts and cultural activities supported mental well-being. Educational activities benefited both mental well-being and health-related quality of life. It can be said, by looking at this table, that different activities work through different pathways to support people's well-being, and also we can see that results made sense, and we can see the picture that we are seeing is what we perhaps expected to see from the theory. Next slide. So when benefits appear, so benefits materialize at different speeds depending on the activity type. So as I mentioned previously, new participants in general gain connectedness quickly just by participating, irrespective of what type of activity they do within the first month. So in terms of the activities now, physical activities show signs of early positive effects on capability well-being. Other activities show sustained benefits throughout the study period from the beginning to the end. Child and family activities and volunteering both demonstrated consistent benefits that were maintained across the entire year. We also found that some activities take longer to exhibit their benefits. Psychological support showed benefits across all well-being dimensions, but these emerged with time. And similarly, physical activities showed extra capability well-being benefits on top of the initial early boost for those who persisted with this activity by 12 months. Next slide. So here we look at dose-response relationships, essentially how the frequency of participation relates to the benefits people experience. So for outdoor and cultural activities, we see a pattern where more is better. And benefits start from the very first session, and they accumulate with each additional session participants attend. So this can be described as a linear relationship, or more is better. So volunteering is good for well-being, so we can see clearly that volunteering is good, but this relationship is complex. So benefits peak at twice per week, but they show diminishing returns, which means that for every session you get less and less. And we reach a point where it does not improve outcomes further. That's around twice per week. And it could be actually counterproductive, so potentially leading to burnout. Other activities, they need sustained engagement. So physical activities, arts and crafts, and educational activities also threshold effects. So you need to reach a certain threshold to see the benefit. So a small amount of participation is not enough to lead to better outcomes, but benefits do emerge with higher participation frequencies. So as I said, you need to reach a certain level of engagement before the benefits can be felt by the individual. Next slide. So if you want to see those patterns, frequency patterns, if you like, visually, that's what we found in the data. So the linear pattern for outdoor and cultural activities, where benefits steadily accumulate. The inverted U-shape for volunteering, where benefits peak and then plateau or decline after a certain level of participation. And the threshold pattern for physical, educational, and arts and crafts activities, where benefits only emerge after a point. So you need to reach a certain level of frequency or engagement to start getting benefits from this type of activities. Next slide. So this is a different way of looking at the data. And to do this, we used an approach called group-based trajectory modeling. So rather than focusing on activities, we are trying to identify the main participant well-being trajectories or the participant well-being journeys over time. So these are the main groups in the study that we have identified, or the type of person, if you prefer that. So we identified 5 main groups shown in the different colors here. So most participants, 44%, were members of group 5, which group 5 is the top purple group, who had good capability well-being throughout the year. And some people, you can see some people that were stuck at the bottom group, around 7%, which is the blue group, the low well-being group, group 1. or some others declined over time, which is the red group. But the majority, more than 80%, are either in good shape or improving over time. And these are the three groups, the purple group, the yellow group, and the green group. And what is interesting also to note here, before we go to the next slide, is that new participants were less likely to be members of the purple group. So the top group, or the top groups rather, consisted mostly of the experienced participants, the people who have been attending for quite a while. Next slide. So this slide, it presents a different type of analysis, which is an economic evaluation, a traditional economic evaluation, commonly used in health technology assessment. So there are well-established thresholds that are used to determine cost effectiveness based on improvements in health-related quality of life. So we know what are the thresholds for COLIs. These thresholds are less established for capability well-being, although a lot of work has been done on that front too. And what we found, so we found that CLOs have good potential for cost effectiveness on both health-related quality of life and capability well-being. So the additional cost for each year in full capabilities generated was less than £36,000, which is well below the £66,000 that UK population studies suggest people would pay for a year in full capability. For COLIs, the additional cost per COLI gained was less than £30,000, but more than £20,000. So it was within the range that NICE typically recommends for interventions. And there is always, in economic evaluations, there is always a lot of uncertainty. And there was uncertainty in these results. I'm not going to quantify the level of uncertainty today. But what we can say is that we can see value generated by these organizations. And we can also say that most people who take part benefit from these organizations. So that is what the results suggest. It was and it is very challenging to conduct an economic evaluation, or in general economic evaluations in this field, due to the lack of comparators. So it's difficult to define the counterfactual, and also it's difficult to follow people who do not get this type of interventions. It might be unethical as well. So I won't go into detail of our methodology here, but there is a paper that we have just published where we explain how we've done this. You can see the paper on this slide as well. It is the Mason paper published in 2025. And I hope that you read that. Especially if you're interested, I would suggest that you do. So the key finding from this paper, and the key finding that you can see on the slide, and I just said that, is that CLOs generate value for most people who are involved by improving or maintaining their well-being outcomes. So that's how we think it's happening. It's less clear what happens to overall healthcare resource utilization. You can see that on the slide as well. So we don't see strong or any evidence that CLOs reduce total healthcare use, which means that CLOs possibly complement rather than replace clinical care. So this can be interpreted as ongoing clinical support and moments of emergency need are unavoidable when you are dealing with people living in chronic ill health. So if you need to speak to your doctor, you're going to speak to your doctor, irrespective if you're going to your CLO or not. However, we do see evidence that CLOs reduce utilization of frontline crisis services, particularly direct mental health services, NHS 24 or 111, and housing support services. And we plan to do more work on this, especially from a realist perspective. So we are doing that, which is to be more specific about what works for whom and in what circumstances. And I'll pass to Rachel now, who will draw on as she said, draw out some key messages for the different stakeholder groups.
Brilliant. Thanks so much, Sarkis, for taking us through that. One of the really exciting things about the realist approach is it does allow us to look in creative ways at the data. And I think Sarkis has shown us some of the different ways in that have yielded different types of understandings. I'm going to sort of broaden us out and try and draw out some headlines and key messages that might be of interest to, and I've thought of you in terms of 4 groups. There's probably more, and there's likely to be lots of overlap in your interests. But just for the sake of organising some messages, I'm going to think first of all in terms of what might be useful to community leaders, people running organisations, people delivering services and activities. And then for people working in organisations that are commissioning or funding the third sector. Then for people with more of a health sciences clinical background, public health directors, practitioners, professionals and general practitioners. And finally, some exciting things for researchers. So there's loads of interesting things for us too. So first of all, thinking about our community leaders. There's an old song, isn't there? It ain't what you do, it's the way that you do it. And I think that Sarkis has shown us that it is what you do, and it's the way that you do it, and that different impacts are linked with different activities and observed at different points in time. And I think all of that is helpful in planning and targeting different activities within community organisations. But the other thing that we have from the whole project is this, as I said at the start, understanding of context, mechanisms and outcomes, how things work. And I just want to show you one of our programme theories. There are 4 programme theories that relate to how individuals experience impacts, and 5 programme theories like that, and another 4 about organisations. So we've got several of these. And I'm going to talk you through one of them and encourage you to follow up on publications to come. So this is a theory that we have tested out on our data and revised according to our findings. It focuses on purpose, productivity and confidence as an area where we think we've got a pathway of context, mechanism and outcomes. There's a lot on this slide, so I'm going to talk you through it just piece by piece, starting by focusing on those yellow boxes. And the yellow boxes describe things that we can actually see, things that are going on in community organisations. And we've clustered these activities together because we can see something similar in the way that they are working and the experiences that people report. So we've put working, making and learning together. Working might be things like a men's shed, gardening services, community gardens. Making might be any of the creative arts and crafts, productive activities, and learning covering knowledge, education and skills. So you get some sense of what we can actually see happening in our community organisations. Now look across to the pink boxes. These are the intermediate outcomes that we see as a result of the activities working, making and learning. And we can pick these up qualitatively and quantitatively, measurably, as Sarkis has shown us. So we know that people talk about increasing their confidence through these activities, their sense of purpose. But we can measure and detect changes in social connectedness too, and mental well-being. So all of these are outcomes that are associated with those activities. Down the centre of the screen in the blue circles are the mechanisms that we think are at work. So people who are doing these kinds of things and experiencing these kinds of outcomes talk in terms of making a contribution, feeling productive. Mostly these are group activities, and so there's social interaction that leads to social connectedness. But there's also something important about having somebody expecting you, having some structure in life, some commitment to showing up, some discipline. And then there's skill development, and for some people that has led to employability, improvements in employability. We've got some good stories in our qualitative data there. Across to the left of the screen in the purple and the grey, those are the contexts that we can see particularly enable these kinds of outcomes. So community organisations are extremely good at providing welcoming, non-judgmental, safe spaces for people to do things gradually at their own speed. And it's particularly helpful to people who are low in confidence or disconnected from employment. So that's an example of how the Common Health Assets Project is undoing the black box, trying to understand the how as well as the what. Now thinking about what might be of interest to those of you who are engaged in the funding and commissioning work of the BCSE sector. Now there's something that Sarkis has told us about already, that good things come to those who wait. So the fast impacts that we can see at 1 month, like social connectedness, might be detected quickly. But some of the more significant and fundamental changes to well-being, we're picking up statistically significantly at 12 months. So somewhere between 6 and 12 months, we're seeing a change that might require actually quite a lot of sustained engagement over time. And I think what that tells us is that there are implications for the funding of community organisations, and that short-term project-based funding might not pick up the impacts as quickly as monitoring and evaluation requires them to. And we might want to see community organisations, in fact, in more infrastructure ways. We also know that for these types of organisation, outreach really matters, and partnerships and trust matter. And so there is something here also about reaching the parts that other agencies may not reach. The organisations we work with are perhaps phoning people who are isolated. They know their communities, they've got community transport, and they're bringing people in. So to public health and general practitioners, well, I thought that some of the findings would be unsurprising to you in a way. We see improved mental well-being and capabilities and health-related quality of life from engagement with community organisations. And social connection, belonging and purposes seems key to that. Whilst we see health improves for some groups, we have a very high level of chronic illness in the sample that we were working with. 2/3 of the sample of the 350 that Sarkis was referring to report long-term illness. And so while we see some signals in our health resource use data, our data are somewhat limited, and we don't see big changes to health service use. We can say perhaps a bit more about the nuance there. The other thing I think is interesting is this idea of coping with ill health and the value of holding people well. And I want to go back to Sarkis's chart and this purple line at the top. This is really important. We know that those people in the purple group are less likely to be new. And so this is a picture of maintaining good well-being over time. This is where all of us want to be. We have to be really cautious how we interpret a line like this. A flat line might be read as nothing changed, no impact. But what we know from our qualitative work, from working with our lived experience panel, is that for more experienced users, it's perhaps more about maintaining, protecting levels of well-being and preventing downward spikes. So finally, for researchers and methodologists, well, there's loads to be excited about and loads of work to do. Realist research seems to have huge potential in these areas of complex intervention evaluation, and that's reflected in the latest guidelines from the MRC evaluation of complex interventions guidelines 2. That speaks much more to a realist framing. Bringing economics together with realist evaluation is an area I think that is developing, and an area of innovation. It's challenging, but it's an important area for us to keep working on. And that final point about our purple line and holding people well poses challenges for evaluation. How do we make sure we're interpreting those patterns properly? And just to finish on the point that Merrin raised about the inverse evidence law, Archie Cochrane, pictured here, and people that followed him did incredibly important work in the evidence-based medicine movement, making sure that very good quality data was informing how we invested and spent resources in the health system. But it does rely heavily on experimental study design. And that experimental study design is not available or appropriate in many of the areas that are most pressing, I think, for research. So in public health and community development, we have to look for something else, something that can cope with complexity and with long and messy causal chains from community action to health and well-being. I think that is possible, and I think it's possible that we can produce robust, credible evidence nonetheless. So I'm keen for questions and discussion. I'll just finish on a big thank you to the 14 organisations that have worked with us over the last 3 years with great patience and will, and without whom there wouldn't be any research to report. Thank you.
Thank you, Rachel and Sarkis. That was tremendous, and we've had some great comments in the chat as you've been presenting there. I've just got, I guess, one question that's come through, which, well, there's two related questions actually, which I thought it'd be worth just asking you before we move on to the panel very quickly. But one is from David Buck. How confident are you in the power of this analysis to distinguish the effects across different activity types and different types of outcomes? And a related question, I think, because it relates, I think, to the type of research and the methods that you've been using, but who are the main bodies funding this type of research? From Esther Warboys.
Sarkis, do you want to start with the confidence around the relationships there between activities and outcomes?
Yeah, it's a really good question. I can say that we are very confident that we can identify these patterns because of the approach used and the sample size. We also applied the correction because we had, even though we had a lot of people, we had 14 organizations, and so we also applied the correction to our standard errors for the relatively low number of organizations, and we could still see statistically significant results after that correction was applied. So it was a high bar for those results to appear. And we also saw consistent results between different models. So it's not clear from the way I presented the data. We ran many models. It wasn't a single model. And the results were consistent between models as well, and that gives us even more confidence. And yeah, in the paper, obviously, we're going to explain all the details behind all the statistical analysis. But yeah, it's as robust as it can be.
Thanks, Sarkis. And then just to add to that from me, the program theories also give us confidence. So there is something that is non-spurious about this because it's located in the experiences of our stakeholders and participants as well. On the funding question, the National Institute for Health and Care Research are our funders, NIHR. They're the biggest funders of health research in the UK. And their Public Health Research Committee has taken a real interest in the more upstream, complex, wider determinants of health, including communities, things like debt, advice services, and in our case, community assets. So that's where we got the funding from. And I think there's a kind of portfolio of funding to different universities and different collaborations in this space by NIHR. There's likely others as well, but that's ours.
Well, that's absolutely fantastic and really brilliant response to that. High confidence levels. It's been really good to hear from you some of the depth of this work today, and thanks also for pulling out what the messages might be for different types of audiences, whether that's community leaders, researchers, commissioners, public health. We have had one question about how are we going to get the results of this out to different audiences, and I think one of the answers for that is it's up to us on this webinar call today. It's up to all of us, and Steph is going to now put in the chat a piece of work that the Health Creation Alliance produced earlier this year, which is a resource kit to help to influence individuals, particularly those who have say or decision making over how money is spent. So we'll put that in there. That's to help you to find ways of influencing the key people who need to be influenced around this, and of using this information in a way to get action and investment in those communities. So without further ado, I'm going to now invite our panel members to come up. So Rachel and Sarkis will disappear, and we'll have very soon Anna Hartley Exec Director of Public Health and Communities at Barnsley Borough Council, and also Shamim Jan, who is Director of Bollyfit Active CIC, and also Anu Singh, who is Chair of Leicestershire and Rutland ICB and Northamptonshire ICB, and also Ben Hughes, who's Head of Wellbeing and Public Health at Essex County Council. So while they're just being found and spotlighted, or spotlit, I think the word might be, I'm going to first go to Anna, just to introduce yourself in 30 seconds, but also then to give a little bit about what this has brought up for you. What's your response, reflections on this research? Thank you.
Thanks, Merrin. So I'm Anna Hartley. I'm the Exec Director of Public Health and Communities at Barnsley Council. So Barnsley has the lowest healthy life expectancy in the country. So we absolutely need the kind of things that have been discussed today. I'm a slightly unusual Director of Public Health in that I spent the first 5 years of my career working for a voluntary sector multi-purpose community centre in Leeds called the Burley Lodge Centre. So I have absolutely first-hand experience of the importance of this work. Merrin, did you want me to sort of just introduce myself and then do a bit more about what kind of my initial reflections?
Yes, yeah.
Great. So I suppose that I come to this, I suppose, with a number of hats on, and I think the point in the chat is so important about how you sell this message to different audiences, because I am absolutely one of the converted. So I saw the huge difference that these kind of organisations made, and the evaluation is absolutely vital, because you need to persuade other people how important they are. But the evaluation, as brilliant it is, to me, it would be almost impossible to capture the depth and breadth of these kind of organisations. So these rooted in place, owned by the local community, I would argue non-statutory. I think that's really important. I think Bromley by Bow is a good example of where the NHS have worked hand in glove with the voluntary sector, but they've done it in a really respectful way where they both maintain their identity. But I think there's something completely different about organisations that are owned by local communities and not by the local authority or the NHS or any other statutory body. So I really believe in that as the key principle. And you know, if there are so many ways that you can talk about the value of this. So if you think about Michael Marmot, I'm coming at it from quite a public health perspective. If you think about Michael Marmot and the concept of proportional universalism, which is you give more to those who need more. So most of the time, these kind of organisations are placed geographically or working with communities who have traditionally been excluded from a lot of healthcare, who've often had poor outcomes due to things like structural racism and inequality. So actually that they are part of the solution to that, and a really practical way to deliver that change that we need to see. A good example for me as well are things like First 1,001 Days, which is a key NHS principle often delivered through these kind of centres. They provide a safe, welcoming space for people. Things like tackling poverty, so that's something that you know, is really important. Somewhere like Barnsley, where 30% of our children live in poverty, these places often provide really practical support. Not just in terms of dealing with day-to-day poverty, but also things like homework clubs supporting children to achieve their educational potential, and supporting like families around welfare benefits, a really strong evidence-based intervention that supports people's mental health. That's a key sort of component of that. I think the other thing that the evaluation, which again is fantastic, but it almost could take it further, is that what I saw, and I'm sure lots of people who are listening to me will have seen it too, is that when you start with an individual, it doesn't remain with an individual, it becomes something about the whole family and the community. So a good example for me is that we would run we'd run summer clubs. Say an 8-year-old, 10-year-old child would come to those summer clubs, then the mum would come along and she'd start volunteering, then the dad would use our welfare benefits advice service, and then the older siblings would often get involved. And actually what we'd see is that for those communities that are some of the poorest in the UK, that actually that would have a huge benefit to them. And one amazing example was some of our local women who had started by attending a DIY club, then went on to do a degree at Leeds Leeds University in Islamic Studies, and the university came and did it, actually held it at our community centre. So, I mean, you can see I'm getting very excited because I just really feel for those people who haven't experienced it firsthand, and I know there's lots of people on the call from lots and lots of different backgrounds, but I really believe that this kind of work, really well described in this evaluation, is what can make a massive, massive difference to our community's health. The NHS neighbourhood agenda, which is kind of flavour of the month, and we've all been there, you know, I think we've been, some of us who are a bit older have been here before, but I think harnessing some of those policy intentions and actually ensuring that some of that resource and energy goes to our communities and actually benefits them is really important, and I'm certainly going to be doing that where I am. Mary, I'm not sure if that's my 3 minutes, is it?
It is.
Right, I shall stop.
So thank you, Anna, because what you've done is sort of drawn the link between the data and what you see on the ground in your work, and that's fantastic. And that's from a public health perspective as well. We're going to now look from a community perspective, and I'm going to ask Shamim Jan to just introduce yourself briefly, but then also give your 3 minutes on, do these findings ring true with you, and do they, more than that, do they deepen? Will they deepen your and your community's understanding of the whys and way forwards of this sort of work?
Thank you, Merrin, and yeah, fantastic presentation. And my name's Shamim Jan, and I'm the founder director of Bolifit Active CIC, which came from a lived experience of not finding a safe space as a Muslim Asian woman to do exercise where I could take my hijab off. So I created it, and 5 years I ran it as self-employed, and now for the last 5 years it's been a CIC. But it's been an amazing journey because I saw the gap in the pandemic time is when I started reading the health inequality reports. If you've not read it, Google it, the BB syndrome, the Begum syndrome, and that's when I realized that Asian women needed Bolifit around the country and maybe beyond. So but when we started, soon the GPs, local GPs started taking note, because the women who usually would go in very poorly would now this time maybe go with a relative and not themselves, but not poorly. So the GPs started asking, where have you been, what you're doing? So Bolifit got heard by the GP surgeries, and they then asked us if we could create a diabetes program. And again, we did, because the National Diabetes Prevention Programme was not working for these women. So for the last 3 years, we've been running that in very highly deprived areas through the GP's referral system. And then we created trauma awareness circles, because again, public health, the Manchester City Council approached us to say, how can we make Manchester City a trauma informed? So we again said we could create something for South Asian women, which we have done for the last year. We've been delivering these circles and healing programs for them, and weight loss challenges. So I have loved what I've heard today. It's been absolutely amazing. It validates what we're doing and what Anna's just mentioned. But what we're stuck on now for the last 5 years, the GPs love us, they refer like crazy, but the funders and the commissioners don't take us serious enough. So they don't fund us for long-term projects. They fund us very short-term, 6 months. And as we've heard, the longer people are in these kind of programs, the better their health becomes. So the other thing I actually picked up, because we deliver fitness, we're accredited by Active IQ. So we actually train coaches from our communities to become coaches. Women Teach Women, which is a great space as well, which was needed. But what I've realized, it said, the physical activity, I'm just really interested to know which physical activities this group, this cohort did, because the physical activity we deliver creates from day one connection, and then within the month they're happier, healthier, energized. So I was really interested to know that. And the other thing is, we've got 5 independent researchers who are working with us to create application to actually research on why Bolifit works, why our diabetes program works, but yet the commissioners and the funders are still not connected with us yet. The researchers are seeing the power of what we're creating. So I think if that's okay, Merrin, I could go on forever, but I'm mindful of the time. Thank you.
Thank you, Shamim. That was perfect. And there's a couple of questions there for Rachel. I think we will come back to the funding question. We don't want it to be all about funding because there's such depth of research here. We want to be able to unpack it a bit, but we will come back to that. So, so thank you. And Anu, as a chair of an ICB, in fact, 2 ICBs who are clustering, gosh, at a very strategic commissioning level and thinking about new providers of health services, perhaps. I don't know. What are your reflections on this? Is it going to offer something new to that will help to change and make a shift to this health creating model?
Maren, thank you so much. And thank you so much for the work behind the presentation. Absolutely phenomenal. So Maren's introduced me with my latest hat, which doesn't really, and I feel like I must compete with Anna for the enthusiasm. So my latest hat doesn't really give you a sense of where I'm coming from around this piece of work. So about 10 years ago, I was literally, similar to many people here, spades in deep, trying to demonstrate the value of community connections across the NHS. I worked for NHS England and was really privileged to be able to pull together a number of work streams. You may have heard of things like realising the value, or working with the Coalition for Collaborative Care, and responsible for introducing social prescribing to the NHS. So some really exciting things, and that was the peak of my enthusiasm. And Maren and I had a catch up a few months ago, and it's felt to me that the last 10 years, whilst the policy agenda has really said, absolutely, yes, we need to grip this, we're still in this space of having to demonstrate impact and almost provide the evidence background that will persuade people. So where I am now is, whilst I'm really pleased to see more and more evidence coming on stream, I'm also really keen that we use that to radically change some of the cultures that are in the NHS and in social care. So I've also been a director of social services, and sometimes my reflections are, if people want to do it, they don't really look for the evidence. So you see that with some health interventions, you see that with some medicines management. There's a wealth of weight and intellect behind them, and almost that has a self-fulfilling prophecy. Whereas with the community or person-centered care, we always have to prove it. So I'm really fighting the good fight to change that as a commissioner now. So as a commissioner, I'm working in the 2 systems that Maren outlined, but the one I really wanted to talk about, I'm also vice chair in South East London, and what South East London has done, simply because it's got such a lot of history, real weight behind it, around local authorities working differently with the NHS and communities across local authorities such as Lambeth and Southwark, and then some really big beasts such as Guy's and St Thomas's, which have got lots of charitable funds, and then some big institutions such as South Bank Centre. Actually, when you've got a lot of that coming together, you can actually invest very differently. So South East London are doing a programme around creative health as part of the ICB. It's really exciting. It's been about 3 years now. And one of the reasons why I was keen to mention it is because I've worked many locations and programmes on with individual communities or individual organisations, working on discharge across the wards or all that kind of stuff. This feels different. This is a wholesale shift into a community-led health model across 6 boroughs in South East London. So that's my new life's work, to replicate that as an operational culture across the ICBs. So I talked about some of the things that are in place there to make it easy. So there is charitable funds, there are big cultural institutions, and there are communities who have been used to working and being invested in by local authorities, and the infrastructure is there. So some of that is some of the core ingredients to make this wholesale. But actually some of it is just a will to take a different commissioning approach. So what we are doing now across the, there used to be 42 ICBs, and if colleagues don't know, What the ICBs are, they are the kind of the bringing together of it was providers, commissioners, local authorities across 42 areas. Now there's been a bit of a shift, hence why minor clustering. We've gone down to 24 ICBs, and we're moving far more into being a strategic commissioner. So less of the kind of marking the homework around ambulances outside of hospitals, which is really, really important, but actually finding our own voice in our space, which is trying to think how we can get upstream and deliver the 3 shifts in the 10-year plan. So the 10-year plan, I mean, as Anna said, you know, we've been here so often before, you know, even before Marmot's, you know, 10-year plan before, there were so many policy drivers that said, hey, we haven't got time to waste. We have to do this and not lose any more generations. And here we are, you know, 15, yes. 20 years later, still there. But now I think we've got a strategic commissioning directive based on population health and the political will to demonstrate the 3 shifts are being delivered, hence the investment in neighbourhood health. So I'm finally quite excited again about some of the opportunities, and I think this research, you know, it reminds me of lots of the excellent work that I was able to do a few years ago, and this has moved us on, you know, exponentially. So I'm so pleased.
Good. I was going to ask you come back to that about the research at the end, and you did. So I won't need to ask you that now. But you, hopefully, then you know, this offers another level of granularity, doesn't it, and another sort of few strings, I think, to everyone's bow in terms of making the case that we've been trying to make for a long time. So thank you, Anu. So coming to Ben, I mean, Anu's already mentioned, you know, strategic commissioning, and I think that you've been in a commissioning role for a number of years now and really doing some quite pioneering work in this area. So from your perspective, Ben, how will this data and this new evidence base help? Bearing in mind we've only seen a small sliver of it, really. There's a lot more of it to come.
Hi, Maren, thank you so much. And thank you to Rachel and Sarkis. Really, really interesting to see. I'm Ben Hughes. I'm the Head of Wellbeing and Public Health at Essex County Council. I'm a Commissioner of Substance Misuse, Health, Homelessness Prevention, Health and Justice, and Complex Needs Services. And by Commissioner, I don't mean I just buy stuff. As a Commissioner, I take my role seriously around place shaping and system development. And I think that's one of the shifts we need to take as well in our understanding of what commissioning is, and shifting away from this transactional purchasing activity to actually working with our communities and working with our providers as a cooperative. I found it really interesting to see the research outcomes. I've been working for a number of years at creating far more community-owned and community-led initiatives. And the research findings that Rachel and Sarkis presented are very much what we have been seeing on the ground. And we are also investing in significant capacity, working with Essex University at the moment around knowledge transfer partnerships and accelerated knowledge transfer programs of work around evaluating the impact of our own community-owned organisations. And it's really good to see that we're starting to gather a body of research and evidence that is going to support commissioning decisions. So my big toe in the water around this was about 8 years ago. I set up something called the Essex Recovery Foundation, a charity that is wholly owned by the community, that we are slowly but surely handing over commissioning responsibility of drug and alcohol services to that organisation. So the actual community will be taking the commissioning decisions around the budget allocated for substance use recovery and treatment services. So they have developed our 5-year strategy. They've developed our commissioning strategy, and they are building the capacity in the community to drive further research through peer researchers and also through their decision making around where we are allocating and providing funding. And I think one of the things that came out of the research for me is this is not a quick fix. This takes a lot of hard work. And whilst it can generate and deliver positive outcomes quite quickly, it is something we need to hold our nerve on, and it is something that will take a significant amount of effort and work on everybody's behalf, but also on bringing the community alongside us. Because I think I saw a question in the chat about are we just switching from services provided by statutory organisations to services provided by voluntary organisations, or are we actually shifting to provision that is truly community owned and community led? And I think that's really quite key in all of this, we need to make sure that what we're doing is creating that real collaborative. And as a funder of the services that we're talking about, it is not my place to control the money. It is not my place to provide that short-term 6-month grant to assuage my conscience and allow me to say I've invested in the community. But it is a real piece of work around investing in communities, and that's not just the money, it's the time, the effort and the input that professionals can have to support the community to really make a difference for themselves. The one thing I would ask of Sarkis and Rachel is about how much further we're going to go around communities of shared interest, because for some of us it's not always just about geographical communities. Some of the communities we're working with are very disparate, but do come together through shared experience. But I think the onus is on all of us to use this research to really change the way that people do things. I think the NHS has a way to go. As much as I think the shift in the ICB's focus is a good thing, and the 10-year plan focusing on the shift to prevention is a good thing, I'm less sure that it's going to happen very soon. I think we're going to see a lot of hanging on to things because money is tight and posts are being lost and there is a lot of uncertainty in the system. My hope is that it will shift, but I think we have to take research like what we have seen presented to us and really use it to try to shift people's way of thinking, because the evidence is there that this works, and if we are really going to be an evidence-led system, we need to listen to it. I think that's probably my hobby horse finished, Mary.
Thank you. And we've got, we're all the converted here, aren't we, today? But
yes.
Interestingly, we're in systems as well and working with systems in Bollyfit are very much working alongside, in Greater Manchester. So can I now take the opportunity to bring in Sarkis and Rachel again, and we'll sort of have a slightly bigger panel, if you like. So for the last few, 15 minutes or so, just a few questions. There's some questions coming up. Well, I just want to first, I think, focusing on this idea that Ben hit on really, which is, I think, what we call community agency. And we talk about investing in community agency, not just investing in communities. And there's a difference there. If we can understand that difference, then and perhaps even articulate it, those are some words you could use to articulate it, that might help. So it is about investing in communities rather than just communities. But it's not just communities providing services instead. It's actually really playing to strengths and developing the agency in communities as well, so that people are enabled to do all sorts of things that they, build. That confidence is built. We talk about 3 C's: connecting to build confidence, to gain control. What does the study have to say about that? Coming back to Rachel and Sarkis.
Thanks, Maren. So I think all of the community organisations that we worked with and the people with lived experience that we worked with know that. That is how they work. They are not new deliverers of old services, or they've been doing community development for such a long time. I'd say, and I don't know if Shamim would agree with me, but I'd say that the sector is quite good at this sort of tactical mimicry. So when the new buzzword is dropped on them, they can say, we already do neighbourhood health, we already do whatever it is, big society, whatever it is that comes to them. Some of our organisations have been really effectively doing what they've been doing for 35, 40 years. So I think community agency is very much what they're about. And the whole piece of work around salutogenesis and the assets-based approach, to me, is that, right? It is building on strengths, and it is building capabilities and relationships. I think possibly the research and the policy people are on catch-up a little bit. So if you look at the literature, the way that that's described in the literature we've looked at has moved from sort of consultation through involvement, through participation, towards a place where we can now talk about community expertise and community leadership. But that to me is a recent phenomenon in the literature. So perhaps it's the rest of us that need to catch up with the community sector on that one.
Thank you. Yes, and it's so implicit sometimes. I think it needs to be brought out and made explicit, because it is actually a key element of what makes the difference. I think as well as understanding what all the different activities, the particular benefits and how they're realised, which of course this research delves into in a much bigger way. Shamim.
Yeah, just come in there. Thank you. Yeah, Rachel, what I always find with the community, and it's not me or the directors coming out with ideas or how to support them, it's the community themselves. And we have a big, culture of where we sit down with our participants, our service users. Anytime we are at a block for ourselves where to go forward now, we sit down with the communities, and trust me, they give us the answers. For example, we did trauma awareness training. We co-produced it with them, co-designed it with the women. And one of the things they did not like is us standing in front of the room and teaching them things. They like to be sat in circles. They like to talk, they like to get involved, they like to speak and be heard and listen. So yeah, definitely. And we're just voicing that at the end of the day. We listen to them, and then we go with what they say, and then we try to amplify their voices. And that's where our success lies, really. Thank you.
Thank you. And just on that one, a few people have talked about, this isn't going to change enough anytime soon. But what we've learned over the years is that you really have to see this to believe it. You have to see it happening and feel it. Just being told about it or shown the figures doesn't really hit. And I wonder, Ben, if that's something, that you've experienced, and how you get across that gap of kind of maybe finance directors, people with the money who really, they don't fully understand what's actually happening in communities.
I think, we've been working with the Essex Recovery Foundation and from its creation for about 8 years now, made all the longer by the fact that there was a minor pandemic in the middle of it all. But I think it's the evidence that is provided by the research that we've just seen presented. It is also that I'm doing it, I can show you it, you can come and visit it. And we've had an awful lot of people interested in the Essex Recovery Foundation. We've presented as often as possible. I don't present. I leave it to the chief exec of the charity and the chair of the board of trustees, who's actually a graduate of our own treatment system in Essex, and introduces himself as a man in recovery from day one. So I think it's sort of do it, show it, prove it, and invite people to come and visit it. Because it's really quite impactful to come and see it happening on the ground. It's really, the evidence is absolutely vital, but it is also the evidence of your own eyes sometimes, and the evidence of the qualitative. And I know, Rachel and Sarkis, you mentioned that there is the qualitative behind it. It is as important to read the case studies, to see the case studies, to see the cases in front of you, and to then go and be with the community whilst they are doing their due. And I think one of the other things that's been really fascinating for me, and I've been commissioning drug and alcohol services for 20 odd years, is that the first time we sat 45 people with lived experience in a room and said, if money was no object, what would you change in the system across Essex? I think they only spent an extra 40 grand on top of what we already spend. They just wanted to reshape the way the whole thing hung together. And they wanted it to be more focused on them than on the clinics that the professionals were running, and a bit more focused on where they could be met rather than where they had to get to at what time. And yes, I totally take the point that this does take investment. And believe you me, the Essex Recovery Foundation is not a freebie and it's not cheap, and we do commit sustainable funding to it. But they didn't want to spend a vast amount of money. They wanted us all to talk to each other better and to talk to them better. So it's been fascinating.
Thank you. And Anu?
Yeah, just I mean, because it's this spot is so fascinating, because we absolutely do have to demonstrate an economic case, and use storytelling, use outcome measures, use community voices to demonstrate that economic case. The challenge for me is when people aren't able to hear the currency that we're talking in. So sometimes the economic case is to the nuts and bolts of the finances. So thinking around counterfactuals, and if you're thinking about a pathway, then how will the pathway be flattened or the curve be flattened? And I think the secret is going to be when we start to say, actually, we can't use that currency anymore. The economic case we're making is a broader economic case around where people are, who people are, and to try as strategic commissioners to move away from that almost too focused outcome of a change to the end game, which might well be less ambulances queuing outside A&E, but it will certainly be a very, very different approach to community-led health and health creation, which in itself has got to be proven to be the merit. And so I think there is something there about, as you said, Meren, we're all kind of speaking to the converted here, but as a group, this is the kind of the leverage we need to pull to try and change the currency that's out there.
That's so important, isn't it? Changing the goalposts rather than you're trying to constantly shoot through the goalposts. Excellent. So I'll bring Anna in now, and then Shamim, and then I think it's probably nearly wrapping up time at that point. Anna, you're on mute.
Sorry, it's messing me about today. So I completely agree with what Anu says, and as a public health consultant, what you realise is the NHS funds loads and loads and loads of things that are evidence-based not to work. So, all sorts of things that they've happily funded for years. And when you try and take those away from people, there's a big kickback. So, a lot of knee surgery, kind of ear syringing, tonsillectomies. So there is something about getting too caught up in the idea that if we can only just prove it's value for money and it works, people will fund it. And really, I think it's a mind shift, and it's a shift in people's values, and this piece of research is really, really important because it supports that forward movement. Sometimes I call it kicking the can down the road. It's not straightforward. It's about constantly pushing. The other challenge is that sadly, because we have a very unequal system, significant numbers of decision makers, nearly all decision makers, have not come from a background where they themselves may have used community-led interventions. It's, I'm a massive convert because I happened to work for one for 5 years. So there is something about hearts and minds. So one thing I did when I worked in Wakefield was I took about 20 GPs and senior leaders down to Bromley by Bow on a bus, and we had a day at Bromley by Bow, and that massively changed the narrative. So then from then on, community anchors became a currency in Wakefield where I worked, and money followed that. So we ended up putting significant amount of money into the community anchors. But that's something, and all of us can play our part, I suppose, in changing that narrative, whether it's about inviting commissioners to your service, working with people like Ben, myself, Anu, to try to sort of change that narrative. But it really, and there's loads in the chat about funding. That's, and it's been ever thus. The NHS is probably in the most challenged position it's ever been in, funding wise. 50% of your ICB colleagues are losing their jobs right now. So this is just to put it in context, it is a really challenging, difficult time, but this is still the right thing to do. And the evidence today is just once again affirmed that it's the right thing to do. It's cost effective according to QALYs. So it's to be welcome, but I think it's about sort of continuing to push on this. I've got a massive comment about misinformation, but I will write it in the chat because I realise it's 3:27.
Yeah, very soon, but I'm going to leave the last word with Shamim.
Yeah. Thank you, Maren. Yeah, and again, going on health economics, we've just completed a 24-week diabetes program in 2 different areas, Cheetah Mill and Levenshulme, and we created health economics report on it, and it saved the NHS from £55,000 to £69,000 in the next 3 to 5 years, with 75 participants in there, not to mention the wider economic benefits to the communities, because these women, once they're empowered with their own health, no doubt look after their families better, their communities better, and become volunteers and all sorts. So I just wanted to mention that as well. And I think we have to keep doing this, like Anna said, keep creating these kind of results, and we will get heard, you know, and there's nothing better than what we do in the communities, I feel. Thank you, Maren.
Thank you, and thank you to all panel members, to Anna Hartley, to Anu Singh, to Ben Hughes, and to Shamim Jan, and of course to Rachel Baker and Sarkis Manukian. And I was going to ask a final question, which is, what difference do you hope this research will make? But I'm actually going to answer it myself because there's no time to go around everyone. But I hope that this gives renewed energy and a kind of waves of energy as more and more of the information and data and evidence comes out, because like Rachel said, it's there's more to come. There's some already published, there's more to come. Let's see if we can keep use it to keep the energy up for change, because it's ultimately that energy and that movement approach that's going to make the change happen. That's why the Health Creation Alliance is a movement. So it's been absolutely delightful to talk with you today. We've been asked by attendees if we can have a list of the questions posted in the chat, make available later, which I think we will be able to, and we'll try and liaise with Rachel and Sarkis to get some answers for those, and we'll email everyone who's attended today and those who registered with some more information, including some answers, hopefully, to some of those questions. We've also had an ask for some of the links that were shared in the chat. We'll put those into the email with you with that as well. And so I think that, as I said, it may be this side of Christmas or it may be in the new year. I'm not entirely sure yet, but we will be in touch with you following this webinar. We will be able to send you the video of it. We will ask if you want to be signed as a member, or let's say we will sign you as a member, but of course there's provision for you to opt out if you don't want to be part of that. Do get in touch with Stephanie, Neil, or myself if you'd like to explore how the Health Creation Alliance can help you to develop out a health creating model or version of neighbourhood health. I think we've got an evaluation which is going into the chat right now, and it would be really helpful to us and to Glasgow Caledonian University if you're able to complete that evaluation. We really do need the information. The feedback for this sort of event is invaluable, and it helps us to shape everything about what we do. So I think that we're done really, and again, thank you so much. I think that this has given the researchers and ourselves some real understanding of the appetite for this information. We'll do our best to be able to make it available in ways that mean something to different audiences. And I look forward to working on this in some way or another throughout next year as well. So thank you all so much, and thank you for attending. And finally, from all of us at the Health Creation Alliance, we want to wish you a very happy, restful and restorative festive season. Thank you.